Hi, I'm Dr. Ruta Nonacs. I'm a psychiatrist from the Center of Women's Mental Health at Mass General Hospital, and I'm also the editor of our program's website, womensmentalhealth.org. And today I'll be talking about the treatment of menopausal mood and anxiety disorders and the role of menopausal hormone treatment. And this is a topic I selected because there are an increasing number of women who are coming into our clinic looking for treatment for menopausal depression and anxiety. And they also have questions about the use of menopausal hormone treatment. And I think this reflects a shift in medical practice. Women are seeing a lot of direct to consumer ads about menopause hormone treatment, which they've not seen in the years previously. The FDA and Health and Human Services have changed the wording around the use of menopausal hormone treatments. And women are very interested in exploring this option for treatment of an array of symptoms. I think one of the problems is it is difficult to find providers who have expertise in the use of hormonal therapies. And this is because most of the OBGYNs and primary care providers started training after the results of the Women's Health Initiative came out in the early 2000s. And this study and others suggested that there were significant risks associated with the use of hormone therapy in older women. And most of these studies were done with older preparations of hormones, which had much higher doses. More recently, it looks as if using hormone therapy with estrogen and progestins is a reasonable option for younger perimenopausal women. So, just to make sure that we're all on the same page, I just want to start out with definitions. So, menopause is medically defined as 12 consecutive months without a menstrual period. So, this is really the cessation of reproductive functioning. And typically, it occurs between the ages of 45 and 55. And in the United States, the median age is around 51. So, although menopause is well defined, perimenopause, which is the time leading up to menopause, is much more nebulous. And for some women, this may occur in their early 40s, it might be 6 months, but for many women, the symptoms can occur over the course of 5 to 7 years or even longer. And what is happening during the perimenopause is that there are fluctuating hormone levels. So, estrogen levels are rising and falling, and these fluctuations occur rapidly and frequently and can cause a lot of disruption in functioning. So, we see irregularity of menstrual cycles. We also see vasomotor symptoms. So, typically, these would be the hot flashes and night sweats. During the perimenopause, there's a high risk of sleep disturbance. There's cognitive difficulties. There are changes in sexual functioning. There are also mood and anxiety symptoms that emerge during the perimenopause. So we really have a lot of things coming together during the perimenopause. You have the hormonal changes, which can lead to sleep disturbance. This is a population in their 40s and 50s who have declining physical health. There's higher rates of type 2 diabetes and overweight, which can also complicate the picture. And there are many psychosocial variables that are occurring during this stage. So, this is a really stressful, vulnerable time in women's lives. And one of the interesting things is, at least to me clinically, is that while you have these vasomotor symptoms and irregularity of the cycles, the mood symptoms and sleep problems can emerge much earlier. So, several years before you even see any clinical symptoms that are suggestive of menopause. So, you can have mood changes in the absence of vasomotor symptoms. And this can make the picture a little bit more complicated because it's not clear, is this depression? Is this the perimenopause. In the end, it doesn't make so much of a difference in terms of treatment, but I think it can complicate matters in terms of deciding who, in fact, should carry out that treatment and where to go if you're a woman with these symptoms in terms of finding a provider who has expertise in this area. So, what we have learned from research is that women are about 2 to 4 times more vulnerable to developing depression during the perimenopause than other times during their lives. So, it's really this period of emotional vulnerability. We have seen that there's an increase in the new onset of depression during this period. This may occur either in the absence or presence of vasomotor symptoms, but we know that severe vasomotor symptoms are a risk factor for depression. Most of the cases of depression we see in the perimenopause are women who've had a history of depression. So those would be episodes at earlier points during their lives. We also know that postpartum depression is a risk factor for perimenopausal depression. So if we see a woman who's had a history of postpartum depression, she's at greater risk for developing depression during the perimenopause, which makes sense because this is another time of hormonal fluctuation. The other presentation we sometimes see is either new or worsening premenstrual symptoms. So we see women who didn't have premenstrual symptoms historically, but now they're noticing that their symptoms worsen during the week before their menstrual cycle or week to 10 days before their menstrual cycle. And then they disappear after they get their period. And these can be severe irritability, sleep disturbance, profound sadness, dread. It can be really a constellation of symptoms that occur, but then they disappear very quickly with the onset of the period. So that's an interesting presentation that you sometimes see in this older population of women. And how do we treat these symptoms? That's the big question. And how we treat the symptoms depends a little bit on who. So, if you take your symptoms because you have depression or anxiety to a psychiatrist, you're more likely to be treated with an antidepressant. However, if you have a more mixed picture where you have vasomotor symptoms or premenstrual symptoms, and you end up going to an OBGYN or your primary care provider, you're more likely to be treated with a hormonal therapy, or that might be recommended to you. And this is because there is data to support the use of menopause hormone therapies for the treatment of moderate to severe vasomotor symptoms, as well as premenstrual symptoms in this population. And there's also data to suggest that hormone replacement therapy or menopausal hormone replacement therapy might be beneficial for women with depression. There have been several randomized controlled trials which suggest that estrogen treatment, mostly estradiol, can be effective for the treatment of depression, either alone or in combination with an antidepressant. However, at the present time, hormonal treatments are not a first line treatment for menopausal or perimenopausal depression. SSRIs and SNRIs are the first line treatment. But if you do see an OBGYN and present with vasomotor symptoms that are relatively significant or premenstrual symptoms, it might be recommended that you start treatment with a menopause hormone therapy. And what we typically use in this setting is a transdermal estradiol. A transdermal is preferred to oral because it is associated with less side effects, including risk of stroke and risk of thromboembolism, also lower risk of cardiovascular disease. And if there is an intact uterus, we must combine the estrogen treatment with a progestogen. And this is usually oral micronized progesterone. So, those are reasonable options for the treatments of these symptoms if you're under 60 and within 10 years of menopause. If one has more depressive symptoms, the first line treatment would be with an serotonergic antidepressant, either SSRI or SNRI. And the reason we use serotonergic agents in this population is that they tend to be better for treating comorbid anxiety, which is very common in this population. And they also might be beneficial for vasomotor symptoms. So, not as strong as an effect as we see with estradiol, but they do appear to decrease the severity and frequency of vasomotor symptoms, which can be a major benefit in this population. So, other things that can happen in the context of this treatment is that we often see either a partial response or residual symptoms. So, especially when we're starting treatment with an SSRI or SNRI, we can continue to see sleep problems. And I think that can be really challenging because you have to wait 2 to 4 weeks for the antidepressants to kick in. And sleep disturbance is really one of the most distressing symptoms in this population. So, in that setting, we might use other treatments to help manage sleep. We do use benzodiazepines in this population. I think the sleep problems can be very problematic because they affect multiple domains of sleep. So we see problems falling asleep, but also problems staying asleep. If it's mostly problems falling asleep, one might consider the use of lorazepam. If it's problems staying asleep, we might use clonazepam. In other populations who are concerned about the use of benzodiazepines. There might be other medications that can be used in this setting, like trazodone or doxylamine. I think they're not as effective as the benzodiazepines, but they could be an option. The other medication that we use a lot in this setting is gabapentin, and usually between the doses of 300 to 1200 milligrams at bedtime. It can be helpful for sleep, and it can also be beneficial for the treatment of vasomotor symptoms. So sometimes the dose is pushed up to very high levels, like 3,600 milligrams a day. At that point, the effect on vasomotor symptoms is probably equivalent to estradiol, but those high doses are associated with a lot of cognitive side effects. And so we typically don't recommend the use of those higher doses. So, in general, this is a very complicated population. So, the other thing to remember in this population is sometimes you can treat the depression and still see significant vasomotor symptoms. So, in that population, we might consider the use of menopausal hormone therapy. And we wouldn't discontinue treatment with the antidepressant, but we might augment with transdermal estradiol with a progestogen. And there are some psychiatrists who and nurse practitioners who do use these two treatments together, but at our site, we typically collaborate with a gynecologist so that the treatment can be monitored closely, as there are risks to using hormone therapy in older women. So, this is a complex patient population where you see multiple symptoms, including depression and anxiety, combined with sleep disturbance, as well as cognitive dysfunction, sexual functioning problems. This is a population that also has higher rates of medical comorbidity, including metabolic disorders and headaches, as well as decreased mobility and physical fitness. Um, there are many treatments that are effective for the treatment of perimenopausal depression. However, it may take a while to get to the right approach, which is most likely to be a combination of various medications and interventions.